Medurstand Understanding Medicine.
I am Professor Azizur Rahman, and we are discussing various ECG abnormalities. And last time we discussed bundle branch blocks, left bundle branch block and the right bundle branch block. I hope you remember that lesson. And this time we are going to take up the further distal block called fascicular block. So this is the last time all this orange we have already covered. Those of you who have not attended my previous videos, I'd like to inform you that all these videos are available on my channel Medurstand, and this time we are going to take up this fascicular block. This is my affiliation. I am Professor of Medicine at Rashid Al Latif Medical College and Senior Vice President, Pakistan Society of Internal Medicine. So we're going to take up fascicular blocks. I hope you remember this anatomy, our conduction system. This is his bundle, this is left bundle, and this is the right bundle. And this we have covered, but then this is left anterior. My cursor is passing over the left anterior. It used to be called left anterior superior because it is anteriorly placed and then it goes upward and supplies the upper part of the left ventricle. It may be called left anterior only or left anterior superior fascicle. And then there's another one which is just bunch of some fiber which goes backward, and this is left posterior fascicle. So block can be in this branch anywhere or block can be in this bunch of posterior fascicle. And let's see if we can figure out, if we can identify on ECG if there is any block in any of these fascicles. So these are two places where there could be block. Right bundle branch block, left bundle branch block has been covered, and today we're going to take up anterior fascicular, this one, or posterior fascicular. We will also briefly discuss bifascicular block and then incomplete trifascicular block and also complete trifascicular block and non-specific intraventricular conduction defect very briefly. Now let's examine this ECG, and as per rule, first examine the rhythm strip, scan from left side to the right one, and every P wave is followed by a QRS complex, and you have as many P waves as QRSs, and there is no irregularity. So most probably this is sinus rhythm. But now we examine the limb leads 1, 2, 3, AVR, AVL, AVF. So what do you see? An experienced person can immediately pinpoint some problem. Do you remember in my first or second video when we discussed the morphology of normal ECG, I discussed that most normal healthy people, 1, 2, 3, all are upright. Limb lead 1, limb lead 2, limb lead 3. All three leads, they record upward complexes. And 2 is perhaps the tallest because that falls along the cardiac axis, mean cardiac axis. And here the case is different. AVR, AVL, AVF. Then we go to the precordial leads, V1, V2, V3, V4, V5, V6. They're all normal. And you also remember that when it comes to frontal axis, it is the precordial leads which matter. So we will focus on the precordial leads. If you have to make a guess about the axis, what do you say? Let's do an exercise. I think the diagnosis is left anterior fascicular block or left anterior hemi block. So I'm going to show you the criteria and then we'll see if the criteria are fulfilled here. First of all, you have to demonstrate that rhythm is sinus. In all peripheral blocks, that is one prerequisite. Before you apply criteria, this actually goes without saying that there has to be sinus rhythm. If it is not sinus rhythm, criteria will not be applicable. So in this case, we have seen that this is sinus rhythm. So first abnormality we expect is left axis deviation. And in this case, what is left axis deviation? Normal axis can range from minus 30 to plus 100. Okay, minus 30 to plus 100, slightly beyond 90. So that is the normal axis. So if you have more negative than minus 30, that would be called left axis deviation. This I showed in the module where we discuss axis deviation. Then we have to demonstrate that the QRSs are normal width, narrow. That means narrow means not narrower than normal. That means they're not broad. This is basically to rule out any bundle branch block. I forgot to mention in my last module that there is no significant axis deviation in left or right bundle branch block. There could be some, but not very significant. But there could be some. So we have to rule out left bundle branch block in this case because this is left axis deviation. So we would like to rule out left bundle branch block by demonstrating that QRSS complexes are not broad, they're narrow. And third is no Q waves in 2,3 AVF. Why is this criteria needed? Because 2,3 AVF all record predominantly downward deflection, and these downward deflection could be confused with QS complexes. QS complexes or Q waves, which is a sign of inferior wall infarction. So we have to rule out that morphology, the inferior wall infarction also, by showing that there is initial R wave, no Q wave. And if you concentrate and if you focus on this, I might be able to magnify it and show you it in greater detail. But see here, there is a small upward deflection. Here again, there is small upward deflection, very tiny one, but even smallest upward deflection means that this very prominent downward deflection is actually not Q wave, it is S wave, because by definition any downward deflection after the R wave is S wave. So these are actually S waves. 2, 3 and AVF again, there is a small R wave. In fact, if there is no upward deflection, but this turning point is very sharp, that is also taken as R wave. So we have to fulfill 4 criteria. Number 1, there has to be sinus rhythm. We have done that. Number 2, there should be left axis deviation more than minus 30, which we will demonstrate right away. I can tell that the axes are more than minus 30, but I'm going to formally demonstrate it. Narrow complexes to rule out a left bundle branch block in this case. The complexes are narrow, and no Q waves in 2, 3 and AVF we have ruled out also. So there is no inferior wall infarction. So these are the criteria of left anterior fascicular block or left anterior hemi block. Please excuse me for using different terms. In the past we used to call it left anterior fascicular, left anterior superior block. I think left anterior fascicular or left anterior hemi block. These are two currently used terms. So let's now calculate the axis. There are 2 methods. Those of you who have attended my earlier modules, there are 2 methods. I will demonstrate the axis by both methods. This will confirm that there is actually left axis deviation, and there will be also revision of axis determination. Now this is the picture you remember, and there are pairs of leads. One pairs with AVF, both are at right angle. Limb lead 2 pairs with AVL, both are at right angle, and limb lead 3 pairs with AVR, both are at right angles, and they have different colors. And this right angle means that if the QRS complex is biphasic, for example in this lead, if it is biphasic, both upward downward deflection are almost equal, then the axes are along this lead, either this word or this word. So I think we're going to repeat this exercise. Now let's see what is our first observation. The first observation, this shows the pair. This is for the sake of simplicity, 1, 2, 3 AVR, AVL, AVF. This is how the ECG is recorded. If you make this crisscross, 1 pairs with AVF, 1 and AVF, and AVR pairs with 3, and this is AVR and this is 3, and 2 pairs with AVL, and this is limb lead 2 and this is AVL. So this is just to remember is this crisscross picture. Now let's see which complex is the first you look for a QRS complex, which is isoelectric. Okay, so isoelectric QRS complex, in this case isoelectric QRS is seen in AVR. Okay, so AVR, this is AVR, this green arrow. So the inference is that axes are at right angle to this AVR, which is limb lead 3. So far we know that axes are along limb lead 3, along the axis of limb lead 3, but we do not know whether the axes are this way or this way. To determine that, we go to the next step, and next step is to see the limb lead 3, because that is pair lead, and in this case the pair is this one. So limb lead 3, it is predominantly downward deflection. If you follow this principle, complex has to be predominantly downward or upward. It can't be biphasic. So the this limb lead 3 records predominant downward deflection. So if you take this lead, so the axes are along the negative terminal of the limb lead 3, and this is at minus 60. This is 0, this is minus 30, this is minus 60. So we have estimated that the axes are close to minus 60 as indicated here. But we just do some more fine tuning, and that is you again go to AVR, the first lead where we found isoelectric QRS complex, and see which deflection is bigger, the downward deflection or the upward deflection. Whichever deflection is bigger, axis will be turned to that direction by 15 degrees. You all agree that in AVR, downward deflection is bigger. So if this is AVR and this is the downward deflection is bigger, so and this is the negative terminal, so we will turn our axis toward the negative terminal of AVR. That means in this way, so minus 60 will be actually converted into minus 45. So minus 45 is the axis. Okay, so I hope you have understood this. This was actually the revision. Minus 45 is more minus than minus 30, so it would be called left axis deviation. So we have already fulfilled other criteria, and we have also demonstrated that axes are left axis deviation. So now we confirm that this is actually a case of left anterior fascicular block. Okay. Now using the other method, the same ECG, same lead, we're using the other method. I told you two methods, and now we're going to demonstrate the other method, and if both methods are applied correctly, the answer should be the same. In this case, in method number 2, we have this picture in mind or on paper. Then you look for the tall or the deepest QRS complex. So in this case, I think obviously it is limb lead 3, this one. So we draw an arrow. Since this is downward deflection, so we draw an arrow along the negative axis of limb lead 3, and the length of this arrow is proportionate to the length of the depth of this S wave. So we have drawn this. Now we pick up another lead. I think let's pick up one, and then in this case the deflection is upward and it is not as tall as this one. So we draw an arrow along the positive terminal of limb lead 1, but slightly smaller than this, and here it is. Okay, so we have drawn an angle here. So now, as if you remember the method, we have to draw a line here and another line here, and we meet where the point, both the point meets, we draw an arrow. Again, the answer is minus 45. Okay, so both methods demonstrate that the axis in this patient is minus 45. That means left axis deviation. So this confirms that this was actually a case of left anterior fascicular block. We have ruled out other differential diagnosis. There is no left bundle branch block. There is no inferior wall infarction. Okay, so this is how you do it. Now this is another example. You scan the ECG. This is a rhythm step. You scan it. This is sinus rhythm because PQRS relationship is intact. No extra beats, no missing beats. And then you examine the precordial leads. You all know, as far as axes are concerned, only limb leads are relevant. So limb lead 1, 2, 3, AVR, AVL, AVF. If you remember your lesson, 1, 2, 3 are almost always upward in normal people. But if this is axis deviation, then if 2, 3 and AVF are negative, then there would be axis deviation. Please note down that there is R wave here, R wave here, R wave here. So this is actually revision. So all three complexes, 2, 3 and AVF, are predominantly downward with initial R wave with the narrow complexes. So what are the frontal axes? This is the tallest, and axes are along limb lead 3 on the negative side. So I would place axis somewhere here. This is limb lead 3, and since it is downward, so axes are somewhere here, minus 60. But when we examine AVL and AVF, AVF positive, this is the positive terminal of AVF. AVL, I'm sorry. This is the AVL, this is AVL, and since it is upward, this is the positive terminal of AVL, so somewhere here. And if we examine AVF, it is downward and it is here. But if you compare both, AVL is slightly taller than AVF. So axes are not exactly between these, it is more toward the positive terminal of AVL, as this one is taller. So the axes are somewhere here. Again, in this case, it is 45, minus 45. So again, this is a case of left anterior fascicular block. I hope I was able to explain it properly and you have understood. Okay. Let's take this example now. A rhythm strip does not show any arrhythmia, and if we scan limb lead, even on the limb lead 1, you notice the problem that normally limb lead 1 shows upward deflection, 2, 3 are upward, and in this case they are upward, but limb lead 1 shows downward deflection. And you all know the positive terminal of limb lead 1 is toward the left hand, that is 0. And if it is inverted, the axes are on the opposite direction. But we just do the exercise. This is left posterior fascicular block. And what are the criteria? How do we know that this is a left posterior fascicular block? The criteria are more or less similar, except that you have to demonstrate that there is a right axis deviation. Like in the left anterior block, first you have to demonstrate there is a sinus rhythm. Then you have to demonstrate that there is a right axis deviation. And if you take 90 as a cut point, anything more than 90 would be classified as a right axis deviation. Some authority use 100 as a cut point, but in this case I calculated the axes are plus 105. So there is right axis deviation, whichever criteria you use. Complexes should be narrow and no other reason for right axis deviation. So left posterior fascicular block is actually diagnosis of exclusion. You cannot be 100% sure. You have to rule out all other causes of right axis deviation. So if you have unexplained right axis deviation, then you can call left posterior fascicular block. In a person who has sinus rhythm. Let's repeat our exercise. In limb lead 1, you have, let's do this one. In limb lead 1, you have isoelectric. So this is limb lead 1, and isoelectric in 1 mean that the lead which is just at right angle, that is AVF, the axes are along this one. Okay, and since AVF is positive, it is toward the positive terminal, and you go again to lead 1 and see which deflection is bigger, upward or downward. Downward deflection is bigger, so this 90 degree will be turned toward this. You will add 15 to this 90 degree, and that will make 105. So these are things, let's do it. Isoelectric QRS in 1. So the inference is that axis is at right angle to lead 1, which is along AVF. And then QRS and AVF is upward, predominantly upward, entirely upward. So the axes are toward the positive terminal of AVF, that is here, plus 90. And then we go to limb lead 1 again and see which deflection is bigger, and this downward deflection is bigger, and the negative electrode of one lead is here, so you will turn this toward this. You will add 15 to 90, and that will. Now let me explain one thing. Why is there so much axis deviation in fascicular block and not in bundle branch block? In bundle branch block, because there is differential between right ventricle and left ventricle, and left ventricle has got so much muscle mass that it actually dominates when it comes to electrical depolarization. So when a differential develops within a ventricle, within left ventricle, axis deviation is more marked. Now let me explain how this differential develops in these two conditions. In left anterior fascicular block, because this part is blocked, the one which goes like this, which depolarizes the anterior and the superior part, this part that is blocked, so this part is depolarized in the later part of QRS complex by unopposed forces coming from the left posterior fascicle. So that is why there is left axis deviation. In this case, this posterior fascicle is blocked. This posterior fascicle actually depolarizes the posterior part of the left ventricle, and in this case the current, this anterior fascicle will depolarize this part and then will go thisward to depolarize the remaining part of the ventricle. So there will be a right axis deviation. So to say it again, left ventricle being a large depolarizable muscle mass, if a differential develops within the ventricle, left ventricle, there is more significant axis deviation than you expect in right or left bundle branch blocks. Bifascicular block. What is bifascicular block? Right bundle branch block plus either left anterior fascicle or left posterior fascicle. That would be called bifascicular block or complete left bundle branch block. How to diagnose these? You apply the criteria of right bundle branch block, which we will discuss in the last module, and then you see axis deviation. So if there is right bundle branch block plus left axis deviation, that would be a bifascicular block, right bundle plus left anterior fascicle. If there is a right bundle branch block plus a right axis deviation, that would be a bifascicular block, right bundle with a left posterior fascicle. Now complete left bundle branch block I have already discussed. So this was bifascicular. Now there is another condition called trifascicular block. What is trifascicular? We can have incomplete trifascicular block, and that is a pattern of right bundle branch block or left bundle branch block plus there is prolonged PR interval. So you have typical right or left bundle branch block plus there is prolongation of PR interval more than 0.20. There are actually other possibilities also. Theoretically, it is possible that one has right or left bundle branch block plus additional AV nodal, first degree AV nodal block. But it is also compatible with incomplete trifascicular block. That means trifascicular block means two fascicles are completely blocked, the third one is weak. Current is passing through the third fascicle but slowly. Then finally, we have a trifascicular block, complete trifascicular block, which is also a complete heart block. It is like we discussed complete heart block, but that was in AV node. If we have complete heart block peripherally situated, like here, you have right bundle and left bundle, both are blocked, or right bundle and both fascicles are blocked, it would be called complete trifascicular block. In this case, the prognosis is much poorer than a block in the AV node, because block in the peripheral conduction system implies that there is extensive damage to the myocardium. That means there is myocardial infarction, and that actually has inherently poor prognosis. And the other reason why these patients have poor prognosis, because if you have distal block, then the pacemaker, the inherent rate of pacemaker is also likely to be slow. So the rate in these patients may be very low, like 10, 15, 20, and that may not be sufficient to sustain normal cardiac output. So this is trifascicular block or complete heart block. Then finally, I think there is non-specific intraventricular conduction blocks. I have not any slide for that, but I'll just describe it. Sometimes you see that the complexes are broader than normal, but they do not fall in any definite pattern. So we call it non-specific intraventricular conduction defects. That was all. I really am grateful to you for listening to this video. I am hopeful that you liked it, and I'm hopeful that you learned something new. And please let me know if you have any queries. I am Professor Azizur Rahman from Medurstand, and really look forward to see you in my next video. Thank you very much.